Let me share with you how we remove large polyps using a colonoscope, what we call endoscopic mucosal resection or EMR. So before we go there, let's talk about the wall of the colon. The colon wall is about 3 to 5 millimeters in thickness. And you have the muscle layer here, and you have the blood vessels here, and then you have the polyp. And when we try to cut this polyp, so for example, we try to cut this polyp, there are a few risks associated with this cut. One, we can hit the blood vessels and they could bleed. That's one. Bleeding is one risk. And if we cut deep into the muscle, we can make a hole. That's called perforation. And if we do not cut the polyp completely, it may come back, otherwise called as recurrence of the polyp. So how do we so the goals of our cut are basically two. One is to make sure that we cut the polyp safely, and the second one is to make sure that we cut the polyp completely. So these are the two big goals for our cut. Before we decide to cut the polyp, we come and examine the polyp and make sure that there is no obvious features of cancer. So that's the first step. And when we look at it, we can pretty much tell for the most part if there is cancer or not. And if there is cancer, then we take biopsies, and then we put a tattoo to help the surgeon, and it will require surgery. So cancerous polyp, the reason why we need to do surgery is we don't know whether the cancer has gone into the lymph node, so we have to clear all of that, and that could only be done by surgery. On the other hand, when we look at the polyp, and the polyp looks benign to our eyes, and then when we inject fluid, it lifts, you can pretty much feel comfortable that this is most likely to be benign, and we should be able to cut it. Sometimes in a very small proportion of patients, the cancer may be hiding inside. That may not be obvious, and only the pathologist can tell us, and then we'll make our decisions based on the pathology report. So next, let's talk about how do we remove this polyp, the flat polyp. So let's go back to the wall of the colon. So that's the wall of the colon. And you have the muscle layer, and you have the blood vessel layer, and you have the polyp. So we looked at the polyp, and we felt that it is looks benign. So what we do is we bring the scope, and the scope is here, and then we inject fluid underneath the polyp. And when we inject fluid, so what happens is when we inject fluid, the polyp lifts away from the blood vessels and away from the muscle layer. So we have the muscle layer, we have the blood vessel layer, and then when we inject the blue color solution, what happens is this layer lifts up, and this is the blue color solution that lifts the polyp up, and then the polyp is away from the blood vessels and away from the muscle. And that makes it easy for us to cut safely, and either we can cut it in one piece for maybe 15-20 millimeter polyps, we can cut it in one piece. And sometimes it's difficult to cut it in one piece, in which case we do these overlapping cuts so that we can cut the whole polyp out. And during this procedure, if bleeding were to happen, we can control that bleeding. So we can control this bleeding if it were to happen. It's not very easy to control bleeding. And the other thing is, by lifting and cutting, you stay away from the muscle. If for some reason the injury goes deeper and leads to a perforation that we can see, small perforations we can close and avoid the need for surgery. That's one of the big advances in endoscopy in the last few years. And if in case it is a big perforation we cannot close, it may require surgery. So once we cut the polyp, so you have the muscle layer, and you have the blood vessel layer, and then you put in fluid here, right? And then you cut that polyp. So the polyp is out, okay? Polyp is out. Once you cut the layer, then if you see blue color layer, then you know pretty much that your cut is where it should be, and it is not deep. And in such cases, you don't have to worry about perforation. The next step is we want to examine the edge for any residual polyp. And if we see that, we get rid of it. And once we make sure that there's nothing that you could see on close examination, we go and cauterize the edge, so that if there are cells at that edge, we get rid of those cells as well. And by doing this, you cut down the risk of recurrence. So we talked about recurrence. So this is something we get rid of it by of it, we could actually avoid that or minimize that risk by going in and putting clips to close the defect. So we put clips and bring the edges together. By doing that, we cut down the risk of bleeding, and This also helps in cutting down the risk of perforation. So once we finish the procedure, there are a few things we need to do so that we can come out well. Usually there should not be any pain, there should not be any fever, and there shouldn't be any bleeding. In order to prevent any complications, we ask our patients to go on a diet for a few days, liquids for a couple of days, a soft diet for a couple of days, and then a regular diet. So, and then we also tell our patients to avoid exertion. So that is also very important to allow the body to heal well without the risk of bleeding. So then what happens? If the biopsies that we send from the specimen come back benign, then we need to go back, depending upon how we cut the polyp, we need to go back and check it at 6 months to make sure that the polyp has not come back, and then 18 months later. So when we cut the polyp, majority of the time we're going to go and cut the polyp and come out because already somebody has already examined the colon, and we don't want the clips to disrupt. So when we go back at 6 months, we examine the scar and take biopsies. And if there are any other polyps in the colon, we remove them. It's the same thing at 18 months also. Following that, depending upon the family history and other factors, one could go to a longer interval for examination. If the biopsy shows cancer, and depending upon the features of the cancer, they may require surgery. On the other hand, if the features are very favorable, one could even go to follow-up. And in those cases, in addition to endoscopy, we also do CAT scan and blood test to follow up. So let me share with you what is our experience at MD Anderson Cancer Center. So I've been doing this for the last over 10 years, and this is what I've been doing, mainly taking care of people who were told to have surgery for benign polyps, and our results are as follows. I probably may have taken care of more than 350 patients who were told to have surgery for large polyps, and these are more than 20 millimeter polyps. And so what were we able to do? So when we cut, we need to ask ourselves, okay, first complications, and are we safe or not? So during the procedure, whatever bleeding that happened during the procedure, we were able to control, and none required surgery. And once they went home, about 3 to 4% came back with bleeding, and we were able to take care of them by just medical management, no surgery required. And how is it compared to other centers or published literature? Published literature reports anywhere between 10 to 15% of them require procedure or intervention for delayed bleeding. In terms of perforation that we worry about, I want to share with you, I've done a lot of animal work to figure out how to close perforations while I was at UTMB, and that's what has been helping me to take care of patients. Immediate perforation, in the last 12 years, I had one patient, and he did not require surgery because I was able to close that perforation. One of the reasons why we don't have many perforations is because we respect the colon wall and look at the planes and try to take care of the resection properly. Delayed perforation, I had one patient who actually required surgery. And he went home after surgery. Right. Then the question is, at 6 months and 18 months, how about recurrence? So in our case, the recurrence is about 3 to 4%. And if I recall, maybe there's one patient out of those 350 patients that required surgery because we were not able to cut the polyp. And one patient where the site was suspicious, but later was cancer, and he also required surgery. And majority, all of them, over 95% of them, were able to take care of it without any further intervention. And if you look at it, what is the published literature? Again, it's about 10 to 15% recurrence rate. So overall, if you ask me, out of 100 people that come to see me, how many of the patients could I take care? Looking at it. So I look at it and make sure there's no cancer. If there's a cancer, we have sent them to surgery. And if the polyp is not stuck to the wall and lives well, we're able to cut. So over 80% of patients out of 350 patients, we were able to remove the polyp and avoid surgery. So that's our experience, and I want to share with you this is possible because of the team. We have a good team, and at Anderson we have excellent technicians who assist in the procedure, and it's really critical to have excellent nurses, anesthetists who work with us, and the CRNAs. Pathologists who help us so that they can make the right call, and that is very important, and also surgeons who work with us. And it's all about the team that makes these things possible. And I'm really grateful to my group at MD Anderson Cancer Center. And we published our work in endoscopy and also in gastrointestinal endoscopy. You can search for that. I hope this is useful. Thank you. You could also check my YouTube channel that has a lot of videos on how we cut different types of polyps.